program to sort out intricate issues with dealing with difficult ALL. So I'll hand over to Vinay for conducting further proceedings.
So good evening all. So as Dr. Shruti already mentioned, so we are really excited to have this difficult to treat ALLs. And so the pattern of presentation would be that PHO fellow will present a case followed by a mentor from the particular team who will be doing a focused review of the recently published How I Treat article and also sharing their center experiences. At the end of their presentation, they would be posting a question slide to our experts who will share their insights, experiences, how they adapt the protocols to the low middle income countries, and help us find practical solutions when we are dealing with such cases in the clinical setup. At the end of each subsection, we will have a question and answer session. We would encourage the participant for the audience to post their questions in the chat box as well. And each subsection will be discussed in half an hour. So the first subsection would be discussion on infant ALL and subsequently PH like ALL. So I would invite our speakers as well as our esteemed experts. So for infant ALL, we have the team from Sion Hospital, Dr. Ashmita Gavde. She's the PHO fellow. She'll be presenting a case, followed by Dr. Purvi, senior consultant in the division of pediatric hemonc at Sion Hospital. And we welcome the subsequent speakers, Dr. Asta from TMC Calcutta, who will be presenting a case on PH like ALL, and then Dr. Preetham, who would be mentoring that session with the rapid review of the article. And a warm welcome to our esteemed experts, Dr. Satya sir, senior consultant and director of pediatric hemonc services at Medanta Hospital, Dr. Rajat Bhattacharya sir, senior consultant at Apollo Hospitals, Calcutta, Apollo Hospitals, Calcutta, and Dr. Srijesh, very close friend of mine, and also currently additional professor in the Department of Hematology at PGI Chandigarh. He's in charge of the molecular cytogenetics and has been doing a lot of work with regards to the PH like is being inculcated in their institute as of now. So with these things, let's begin. I would pass on the next presentation from Sion Hospital team, Dr. Ashmita. You can take over.
Good evening, everyone. Shall I share the slides or?
Yeah.
Is the screen visible to everyone?
Yes, it is visible and it is in slide screen. Yeah, slideshow.
Shall I begin? Good evening, everyone. I'm Dr. Asmita. I'm an IB fellow from LTMG Sion. We'll be doing a case presentation on infantile ALL today. So here's my case. This is a 6-month-old male child for non-consanguineous marriage hailing from Bihar, presented with a complaint of fever on off since 2 months. The parents noticed increasing paleness of her body since 2 months. On examination, the patient had enlarged liver and spleen. The CBC picture was suggestive of bicytopenia with increased WBC count of 27,500. On bone marrow examination, the flow suggestive of acute leukemia with CD19 positive, CD10 negative, and CD33 positive markers. The conventional cytogenetics was suggestive of MLL rearranged cytogenetics. On diagnosis, the patient was infantile BALL, MLL rearranged with intermediate risk infant risk stratification and high risk as per the BFM stratification. The patient was started on BFM 2002 modified protocol. Alongside that, we started an antibiotic prophylaxis with posaconazole, Septran, and IVIG for the patient. On day 8, the patient had poor prednisone response and CNS status was 3. During induction, the patient had port site infection. There were steroid-related toxicities. And end of induction, the MRD showed induction failure with the 18% disease. Patient was shifted to a high-dose cytarabine arm of I2A protocol. There were treatment interruptions due to bronchopneumonia requiring HHFNC, neutropenic enterocolitis, and septic shock. During this illness, there was disease progression seen in the patients. So the parents were counseled regarding the patient condition, prognosis, and the parents opted for treatment with palliative intent owing to the social and the financial issues. The patient eventually succumbed to disease progression. So the challenges that we face during treatment with infantile leukemia is the limited access to investigations and treatment in LMICs, the lack of experience with infantile chemoport insertion, multiple treatment interruptions, resistant disease, restricted access to novel therapies, immunotherapies, and bone marrow transplant in LMIC setups, social and financial issues, and lack of robust supportive care. So this is our case. So my mentor, Dr. Purvi ma'am, would take over for the review of the article now.
Yes, yes. Thank you, Dr. Asmita, for presenting that challenging case and how it highlights the biology of infant ALL, how different it is from the pediatric subgroup of ALLs. So I am here to review one of the articles in the Blood Recent series, How I Treat series, How I Treat Infant ALL by Jack Bantrim, Philip Ancliffe, and Ajay Vora from Gosh, London. Next. So understanding and defining infantile ALL, actually Dr. Asmita's case has highlighted everything. It is defined as any onset before 12 months of age. It's an aggressive subtype of ALL, generally presents with an immature, that is CD19 positive, however CD10 negative, immature pro-B ALL with a unique biology and clinical features. Now, based on the molecular classification, there are two subtypes. One is a KMT2A gene rearrangement or the histone methyltransferase 2A gene rearrangement seen on chromosome 11q23, which leads to multiple fusion partners. And this changes the biology and it's responsible for 80% of the infantile B-ALL. The challenges in treatment of ALL are highlighted with Dr. Asmita, and we have this, usually this subset of ALL is present in 80%. Now the next, we have the other subset where the KMT2A is not rearranged or the wild type or the germline. This accounts for 20 to 30%. The authors in the article have, however, recommended that molecular studies are to be done for this subset because PAX5 rearrangements have a slightly poorer outcome or a worse prognosis compared to the NUTM1 rearrangements found in the KMT2A infant ALL. Now, infants with KMT2A germline, they have usually later onset. So later in infancy, they present. They have a more mature subset. So they are CD10 positive, CD19 positive, less aggressive, do well. Hence, the recommendations are that they are treated with a prednisolone prephase followed by MRD-directed childhood ALL treatment. Mentioning the rare subtypes, we have MPAL, which is acute leukemias of amorphous lineage, biphenotypic or lineage switch during treatment. This accounts for less than 2%. Here, the treatment recommendations are that B-MPAL with CD19 positivity has to be treated with an infant ALL guideline and incorporate BLINA in the protocol. And myeloid-directed high-dose cytarabine blocks may be considered when there is a lineage switch, which should be closely monitored. Infant T-ALL, which is again rare subset, less than 2%, is treated like a KMT2A germline or a wild-type ALL. Now, based on the interfint protocols, the authors have proposed a risk stratification and modified the risk stratification. So what the Interfint 06, which was the largest collaborative trial, it showed that all the low-risk patients were the KMT2A germline or the non-rearranged patients. High risk was all KMT2A rearranged with less than 6 months of age with a white cell count of more than 3 lakhs and or a poor prednisone response. And all the other KMT2A rearranged fit into the intermediate risk. So everything which was germline was low risk. Now, how Interfin 21 refined this by incorporating MRD. So high risk also included an MRD response, that is the day 33 MRD more than 1%, or post one cycle Blina when the MRD was still more than 0.01%. This subset was high risk. Now, why this was refined? Next. This risk stratification showed that MRD is not only a key for early relapse prediction, but also helps to monitor patients on immunotherapy, which was the backbone in the Interfin protocols from Interfin 06. And it allows early selection of patients who will benefit from stem cell transplant and or novel therapies. Unlike the other Japanese pediatric leukemia lymphoma subgroup, where CNS status or CNS involvement was included in high risk, authors have not recommended including CNS status in risk stratification. And though the KMT2A partner genes or the fusion proteins have a prognostic implication, again, they have not been included in the risk stratification. Next. So what are the lessons we have learned, and why is the need for a novel approach in this subtype of infant ALL? So mainly there are 3 infant-specific collaborative group protocols which have worked on infantile ALL. One is the North American or the COG studies, which definitely showed that there was a dismal outcome in the MLL rearranged. So they tried to intensify treatment. However, it just led to more toxicity. They did not use the dose and the age modifications which have to be done in infants. But again, there was early relapse, there was more toxicity, and the event-free survival, what was reported, was only 33.6%. The current refinements is they have added risk-adapted FLT3 inhibitors in the MLL rearranged cases, but again, the outcomes have not greatly improved. Then comes the Japanese pediatric lymphoma leukemia subgroup, which was having a high cohort. What they showed was there was a high rate of relapse in spite of CR till the patient reached the transplant. Now, they had a high subset of patients who were in the high-risk subgroup because they included CNS disease at diagnosis at high risk. So many of them went into the high-risk arm, but before they could benefit from the transplant, eventually many of them relapsed. So in spite of a better outcome because more were transplanted, still the event-free survival was not that great. And then we have the largest, which this article discusses, the Interfin protocols, which laid down the guidelines of a hybrid protocol, as this was recognized that these blasts are stem cell-like with myeloid markers. So there was a need of intensification, addition of myeloid-like or a hybrid protocol, though there was no benefit in the late intensification. These were the early Interfin 99, which reported an KMT2A rearrangement showed only an overall survival of 43.2%. The largest study, which includes the maximum patients, around 600 infants in the Interfin 06, showed that the overall survival was still dismal in spite of refining the intensification, adding more toxic myeloid components. However, there was no much difference in the overall survival as compared to the 99 trial. However, when an arm of study in the Interfin 06, when blinatumomab was included, this is the game changer, we see that the overall survival has nearly doubled from 48% to 93.2%. And this paved the way for blina only to be added upfront in all KMT2A rearranged infantile ALL. Next. So this is just to show the treatment overview, which is discussed extensively in terms of blinatumomab, which was the game changer, that this was a hybrid protocol. The induction was quite intensive. It had a 5-drug induction with Ara-C and daunorubicin given subsequently day 8, day 9. After induction, as we can see, all, whether they were medium risk or high risk, received a cycle of blinatumomab. After that, they were given lymphoid versus myeloid depending on the MRD response, which the refinements came in the Interfin 21. And based on that blina response, so there was continuous monitoring of MRD even during blina, day 15, day 29, post blina. And this showed or paved way whether we should use a myeloid-like or lymphoid-like chemotherapy. and also paved way for a second cycle of blinatumomab in a certain section. So high risk was pretty simple. You give the 5-drug interferent-like induction, that is 5-drug induction, followed by blina. And then if they have a good response to blina, so if the MRD clears after blina, they go for stem cell if the donor is available or some sort of bridging chemotherapy. If donor is not available and the MRD is high, then comes way for novel therapies, CAR T, and eventually stem cell. Whereas medium risk, next slide. So this is what this study actually, what I already mentioned, that this interferent group phase 2 study, which showed that when blinatumomab was added post-induction in all the MLL rearranged infantile ALL, which was CD19 positive, and there was a long-term follow-up about 2 years, it showed a 90% response or MRD clearance. So there was improved outcome, deeper and faster MRD clearance, and also no reported lineage infidelity. So this paved way for blinatumomab for all CD19 KMT2A rearranged infantile AL. Next. Now, what was the rationale of the second cycle of blinatumomab in medium or the intermediate risk? So when you have an intermediate risk ALL, post-induction MRD guided us. So when the post-induction MRD was a good response, that is less than 0.05%, the patient went on for a second cycle of first cycle of blina post-induction, followed by a lymphoid-like or the protocol 1B, and there was recommendation for blina cycle 2. Next. However, the authors in this article recommend that do not give the chemo block to reduce toxicity. And after blina 1, those who have shown a favorable MRD clearance in the intermediate risk follow back to back with the blina cycle 2. However, they were worried that there would be recrudescence of the disease because of the resistant disease. So blina was given within a 1-week gap rather than the pediatric protocols which maintain a 2-week gap. So this was the second one is when the MRD was high, that is 0.05%, but not induction failure. Blina was followed by myeloid type of blocks, and then there was blina 2. And of course, high risk went in for a stem cell transplant. Now coming on to the role of triple intrathecal therapy, again, as the authors discussed in the Interferent 06, there is high risk of CNS disease at diagnosis as well as CNS relapse. The isolated CNS relapse reported is 12%, combined relapse is 13%. Hence, triple intrathecal therapy was recommended for all in the Interferent protocols. However, during consolidation with blina, the authors recommend using dual IT to avoid concomitant neurotoxicity with the use of cytarabine. Now, what are the rationale for stem cells? As we have learned, all high risk or poor response to induction, they go for stem cell. The main key point I want to highlight is they should go for an early stem cell transplant. So as soon as a deeper and a faster MRD clearance is achieved, if the donor is available, they should go for a stem cell transplant, because most of the patients are relapsing within first 6 to 9 months. So if they go up to consolidation and they continue chemotherapy, then it is a very poor chance that they would reach the transplant. Medium risk subset or the intermediate risk, if they are on the chemo blocks, but they do not clear or pre-DI, if the MRD is still high, more than 0.01%, they also are recommended for stem cell transplant. So timing should be early. Conditioning, of course, in infantile, we would not prefer a radiation-free conditioning, so that is not recommended. Challenges learned to bridge the patient to transplant, novel therapy should be considered where we can reduce the toxicity. However, there is a concern of late effects and sequelae. Now, treatment overview of CAR T. The authors mentioned that high-risk patient and intermediate-risk patient with end of induction high MRD, so more than 1%, or any residual CD19 disease after the first cycle of blina, these are the ones who will benefit from CAR T. There is no consensus yet where the CAR T should be incorporated or which subset of the high risk will get the CAR T. However, it's those subset which do not have a response to blina. Challenges will be faced because these infants come with a high blast count. They have a low circulating blood volume. They do not have a mature T cell immune system, which will have technical effects. And how do we do an auto CAR? during the apheresis. And also there are concerns about neurotoxicity in this age group. And this paved way and many trials for novel therapies, because again, these blasts are like stem cell blasts. So what we can target, which reduces the toxicity. So Blina is not anymore novel. In fact, it is upfront, as we've already discussed. CAR-T can be offered in Blina resistant protocol when the Blina is resistant post first cycle. And many protocols like the St. Jude groups, that is a TINI study, has included bortezomib and vodinotostat, and they are also studying MEK2 inhibitors upfront in the protocols to see the outcomes. There is also mention of FLT3 inhibitors in the latest COG protocol, which is included in their arm, and a role of BCL2 inhibitors, as these stem cells have overexpression of BCL2. Next. So in spite of what the outcomes have shown, that they were about 40-50% in these protocols, but the supportive care in these protocols was so robust and aggressive that they had full hospitalization of these infants, most of the centers, throughout the treatment except the maintenance phases. There were stringent exchange transfusion guidelines laid down for hyperleukocytosis, rasburicase for TLS, intensive prophylactic use of GCSF, intensive empirical antimicrobial antifungal prophylaxis, use of prophylactic IVIG 3 weekly, and the Japanese protocols also used prevention of RSV. So drugs like pembrolizumab was incorporated in the supportive care. In spite of these robust and aggressive supportive care, we see that still this subset, the outcome is dismal. Yeah, next. Yeah, next, Jasmine. So what the key takeaways or the summary from the authors are: you offer an open clinical trial if available. In a certain subset of the KMT2A not rearranged or KMT2A germline, molecular diagnostic testing is recommended to detect PAX5 and NUTM1 mutations because they have a prognostic implication. MRD assays are to be done by flow, KMT2A PCR, and immunoglobulin TCR receptor PCR. For the KMT2A rearranged BALL and B-cell myeloid MPAL, they will get a predni prephase followed by an interfint or a hybrid side induction. Blina for all KMT2A rearranged CD19 positive infantile ALL. Triple IT for all the patients. Early stem cell transplant for the high risk. Consider a CAR-T if there is non-response to CD19 or no suitable donor available. And the KMT2A germline and the infant ALL, who are the pediatric prototype, they receive a predni prephase followed by an MRD directed childhood ALL treatment protocol. Thank you. So just like to show our center experience with infantile ALL in the past 5 years, that is from 2019 to 24. We have total of 13 patients with a striking male preponderance. So out of 13, 10 were males. The WBC count was more or less than 3 lakh, more than 3 lakh, almost same. We had not many infants with CNS disease. So 9 were CNS1 because our ITs were done on day 8 after the predni prephase. KMT2A status. So the rearrangement or the MLL positive was in 10 patients or 77% of the patients, collaborating or showing almost a similarity as the other centers where KMT2A rearrangement is more common. What protocols we have used? So we have tried, initially we used to use the Icicle high risk. Then we used modified BFM 2002 high risk protocol. We modified it when some of the infants we could not give the high risk blocks. We tried interfint 06 into 2 infants. Unfortunately, we lost them both during induction, one day 15 and one day 18 of induction. And upfront palliation was offered to 2 patients. Next. So this is what we have, the risk stratification, what we saw in our center. 77% were high risk and 15% were low risk, with we really can't talk about the outcome, because out of the 4 infants who are alive, they are all currently on treatment. 2 of them are KMT2A germline and 2 of them are rearranged. Both the KMT2A wild type are on maintenance therapy doing well. 2 KMT2A rearranged are on modified BFM protocol. One is on maintenance and one has just completed the high dose protocol, the high dose methotrexate blocks. So what we feel, based on our limited numbers, we are not yet confident to use the Interfin 26 as we lack the robust supportive care, and we've been comfortable in using BFM modified protocols in our setting. So our questions to the experts, based on our experiences: how do you choose a protocol for a lower middle income country, BFM versus Interfin? Is Blina considered the ideal consolidation in our setup due to availability and cost? Who are the candidates for stem cell? When to offer a stem cell? And what would be the conditioning regimen? And just to share experience of other centers of infantile ALL, pan India. Thank you.
So thank you, Purvi, for an excellent presentation. And thank you to Dr. Smita also for discussing this case, which was actually a very, very difficult case. So now coming to the questions you have put across, how to choose protocol in low middle income country, BFM versus Interfent. So ideally, Interfent is something which is the best protocol which has been there, and most centers are trying to use it. Although the agents are similar, but the intensity is more because it's a 5-drug induction instead of 4-drug induction. There's a lot of mucositis. So it's very, very important that if supportive care is not very good, then don't go for Interfent because it is quite intensive. And if you are comfortable with BFM, I'm okay with that. At least the treatment-related mortality will go down. So it depends on the supportive care and your experience. You may choose the protocol accordingly. But in an ideal world, Interfent is definitely better. And with good supportive care, it is very much feasible to do the induction and everything. We in our center are always using Interfent. Then coming to Blina is ideal consolidation, low middle income company, low middle income countries due to availability and cost. So the data in NEJM, which has been published, and that is very, very impressive. And it shows a jump in overall survival to double, like 48 to 92%. And it sort of tells us that this is the way to go.
Yes.
And plus, the infants, they can't tolerate very toxic treatment. So there is, in fact, they get a break from chemotherapy for almost 2 months with Blina. And the main thing which this paper showed was that, okay, in the high risk arm, they all reach, like MRD negativity is very high and transplants are more feasible. So patients can reach transplant with less morbidity, less infections, and less chemo. So they possibly can tolerate transplant better. And in the intermediate risk group, they showed that many of the patients which previously were eligible for transplant because they were MRD positive after chemotherapy, now with Blina, more MRD negativity was there. So in the intermediate risk, many patients avoided transplant because they were MRD negative. So that was again benefit for these small infants. Avoiding transplant is a great thing, great news, and survival was very good. So it looks like this is the way to go. But yes, Blina is not approved in India. We have to import it. It's very costly. And so these are the challenges. But I think in coming couple of years, maybe a generic Blina would be there. In 2026, the patent is getting over of the Blincyto company. So other companies will make it and some Indian companies will make it, and it would be low cost and available in India. So we have to wait for some more time. But Blina is very exciting addition to this protocol.
Yes.
Who are the candidates for stem cell transplant? That you have highlighted in your algorithm, and I agree with that. Those who are high risk, they all need transplant, and intermediate risk, if they're MRD positive after Blina, they should be considered for transplant. So that's quite straightforward. Then what conditioning regimen should be used? These are infants, so we can't give radiation, that you have already mentioned in your presentation. So TTF regimen, that's thiodipar, triosulfan, fludarabine-based regimen has excellent outcomes, very well tolerated in infants, and that's what should be offered to these small babies, and that is very well tolerated. Real-world experience of infant ALL. So, if you go by the published data, there is not much published data from India, which tells the story that how challenging these cases have been across the centers. And even case reports are lacking that somebody has been cured with MLL positive long-term survivors. So that tells a story in itself that we have improved ALL outcomes in India by leaps and bounds in most centers. But for infants, the challenge still remains. And in my personal experience, like most MLL positive high risk infants, despite doing all the best, most have relapsed again. So it is a challenging disorder. Although few have survived till 7 years, 8 years, that's I have few in follow up, but it is definitely challenging one and costly affair. Most patients in India can't afford this much of cost and everything because they stay in ICU, supportive care, and adding Blina to this will make it like go them broke. So we need some more options, low cost. Another good news is that menin inhibitor, revumenib, is something very exciting oral drug, which like this MLL, this infant ALL with this gene rearrangement, they have this HOX gene, which there is a arrest in the differentiation of these cells into normal cells, and they convert into blast. And menin is the co-protein which binds to this HOX. And if we inhibit menin, then the HOX protein is unable to inhibit this, and the cells can differentiate into the normal cells. So this is something which is likely to, if it can be added with chemo, it may help cells control the disease better and maybe reduce the cost if this drug is also made in India by some company. So that can be another futuristic approach, hitting multiple targets like you mentioned, venetoclax and this menin inhibitor and Blina and all these things combined together may improve outcomes even more. So, but definitely it's good news. We are in good times for infant ALL. Hopefully outcomes would improve in India. Thank you so much. Okay.
Thank you.
Thank you, Dr. Yadav. We have a few questions in the chat box. I'll take two of them in the interest of time, and I would request you to answer the rest of them in the chat box.
Sure.
And so, Dr. Shreyas has said, what is the rationale for omission of MARMA in favor of the second Blincyto, considering that it has high dose methotrexate and Ara-C, which is for CNS prevention?
The data is not there that whether it should be given or not given, because we need an RCT to remove it. That removing high dose methotrexate from infant ALL, would it lead to more CNS relapses or not? So that's the question which is open. Logically, I think it can be removed because Blincyto has T cells are involved and it may help in CNS disease clearance. But I'm not sure. So the data is required. Maybe the next study may try to reduce it. If the survival stays 90% plus in the current study, they may reduce chemotherapy further. Or maybe there would be chemotherapy-free options for infants. That's the future I see. Thank you.
Can I say something?
Yeah.
Yeah, Satya, I think Satya has explained everything. So while I was in the UK, of course, the infant and babies was in the hospital for a very long time, and you went to a transplant, and even smaller ones were cured. And but then back in India, about 14 years ago, when I had the infant ALL, Revati said to me, "Do not treat. These children are not salvageable," which I then realized later why it was the case. And in Singapore, when I had the first infant ALL, I wanted to use the Interfant 06, but my colleagues said to me that don't use it, it's too toxic. And then I understood what the rationality was. It was very difficult to manage with all the intensive Interfant 06. So the strategy they took on about 35 children is to use a standard BFM protocol and take them to a transplant, the rearranged ones I'm talking about, very young ones, take them to a transplant using a FTT based regimen. So that actually improved the outcome. It was actually quite comparable to the Western data. I just listened to Rob Peters last week. What he's saying, somebody needs to be very brave, and the introduction of blinatumomab has completely changed. So they are yet to reduce the toxic intensity too much, but maybe it will take somebody very brave to just put blinatumomab and reduce all the intensive blocks. So yes, maybe a high risk induction, and then probably blina at the moment 2 cycles, what the UK group is doing. And that probably will be the way forward to reduce the toxicity. So I don't know what the ideal, how I treat infantile in India is a question, right? But looks like that intensive chemotherapies are not the way forward. It has to be immunotherapy, which is will be blina based and maybe CAR T based in future. So that will be the way forward, I think.
Sure. Thank you, Dr. Rajat, for that input. So you've already mentioned, Dr. Yadav, about the FTT regimen for the stem cell transplant. So what Dr. Chintan wants to know, is there any role of post-BMT CNS prophylaxis for relapse prevention?
Great question, but answer is I don't know. Very few infants are there in my follow-up. It's a rare disorder. All centers have very less experience. And to answer specifically CNS disease, my experience is very limited. So I don't know. Sorry.
I agree with you. Interesting questions, and many questions are yet to be answered. So I would apologize to all the participants that I can't take all questions online. So requesting our experts to please answer them in the chat. Thank you, and I hand over to Vinay for the next talk.
Yeah, thank you. So much of exciting crosstalks. So we'll move on to the next subsection, discussion on PH like ALL. So I hand over to Dr. Asta, the fellow from TMC Calcutta, to start a presentation.
Okay. Good evening, everyone. Am I audible?
Yes,
Am
Asta,
I audible?
Yeah, you're
Good
audible
evening,
and your
everyone.
slides are.
I'm Dr. Asa, fellow from Pediatric Hemato-Oncology, Tata Medical Center, Kolkata, and I'll be presenting a case on Philadelphia-like acute lymphoblastic leukemia. Our case is a 6-year-old girl from Bangladesh who presented with history of intermittent fever and right periorbital swelling for 2 months since June 2020. And notably, she had history of steroid intake for 5 months. And on examination, there were multiple erythematous form skin nodules and suspicious of leukemia cutis, and she had non-bulky hepatosplenomegaly. So for the diagnostic evaluation, we had done MRI face with brain screening. Here we can see hyperintense signal intensity enhancing area in the preceptal region of bilateral orbit along with the bilateral check. But there was no intracranial involvement or optic nerve free of involvement. And for the diagnostic evaluation, bone marrow showed 90% blast, which was consistent with the acute leukemia. And on immunophenotype, there was 74% gated cells in the blast window expressing CD19, CD10, CD79A, 20, TDT, and SLA DR positive. So FISH panel was run. We can see this FISH image of BCR ABL, where dual color fusion probe was done, and the BCR is labeled with the green signal fluorescence and the ABL with the red one. There are the cells show normal green signals with ABL particles, and there is three signals of the ABL1. But there is no any fused BCR and ABL signals. Meaning there is no BCR ABL fusion, but some sort of ABL1 rearrangement. So ABL1 break-apart probe was done, which shows some signals. There is combining of the 5' and 3' ABL1, meaning there is the normal ABL1 gene, but there is split of the red and green signals, showing that there is some sort of ABL1L rearrangements. So FISH was negative for ETB6, RONEX, BCR, ABL fusion, KMT2A, but positive for ABL1 gene rearrangements. It was present in 84% of the cells. And the cytogenesis karyotyping, there was a structural abnormality seen in the Q arm of chromosome 9 and 10, and there was one unrecognizable chromosomes present, and addition of the 18 chromosome. So it was 46 XX with translocations between 19 with 18 extra chromosomes. So the diagnosis was BCP-ALL high risk. Date evaluation could not be done in view of prolonged steroid intake from outside. She was CNS1 Philadelphia-like. So treatment was started on the Icicle 14 protocol. She received induction and she sailed throughout the protocols. There was no chemotherapy interruptions. At the end of induction, bone marrow was in morphological remission with flow MRD negative and FIS was negative for ABL1 gene rearrangement. TKI is imatinib was started towards the end of induction, and she completed her anti-metabolite on the August 2023, and imatinib was stopped till July 2024. We evaluated her last 2024, and she was in clinical remissions and doing well. So this case shows the importance of molecular characterization in Philadelphia positive BCP-ALL, especially in case of Philadelphia-like BCP-ALL, and the introduction of TKI is imatinib in this case with the treatment regimen leads to better outcomes. Now I'd like to hand over to Dr. Preetam for the rest.
Thank you, Asta. So at the outset, I will thank the organizing committee, especially Dr. Vinay, for giving this excellent opportunity to discuss Philadelphia-like ALL in children and AYA population. So the discussion would center around this this seminal paper, which has been published early this year in Blood in the How I Treat series on pediatric hematolymphoid malignancies by these two excellent faculties of pediatric hematology oncology. This gentleman, Thai Tran, who is a faculty of pediatric hemato-oncology at Charles Brown Cancer Center at Montreal, Canada, and this beautiful lady, Dr. Sarah K. Tassian, who is a faculty of medicine and pediatric hemato-oncology at Children's Hospitals of Philadelphia. So what's PH-like ALL? So PH-like ALL is basically a quite genomically heterogeneous group of BCP ALL, with the commonality being a gene expression signature, which is very similar or identical to the gene expression profile seen in BCP ALL that harbors the canonical BCR-ABL fusion, but the beautiful thing is that this PH-like ALL, it never harbors that canonical mutation. So not harboring the PH chromosome, but having a gene expression signature, which is identical to that of Philadelphia chromosome positive BCP ALL. That's the peculiarity of this PH-like group of ALL group of disorders. Another commonality is that uniformly they carry a dismal outcome despite the modern era of re-stratified management, including the inclusion with the advent of the molecularly targeted therapies, the outcomes remains dismal. So this entity was in discussion for some time, and the debut in the WHO classification of hematolymphoid malignancies happened just 3 years back in the year of 2022. Well, so why are we talking and wasting time on the Friday evening talking about this disease? Because this is a challenging entity. It often carries adverse clinical features. As I said, the relapse-free survival is often meager. There are certain actionable genetic lesions and new tyrosine kinase inhibitors. Some are already in the clinical practice, and a wide range of molecules are in the horizon. And the diagnostic pathway could often be very challenging, especially in the resource-constrained setting. So how common is this? It constitutes around 10 to 12% of childhood and AYA population ALL, and around 15 to 20% of the NCI high-risk disease. The peak incidence is seen in the AYA population, as has been shown in this NEJM paper. So what are the common genetic lesions? So as we can see from this pie diagram, CRLF2 rearrangement constitutes around 2/3 of the all PH-like ALLs. Second in the rank are the ABL class rearrangements, of which the top is PDGFR-B fusion, followed by ABL1 fusions and CSF1R. And then you have different non-CRLF2 JAK-STAT pathway alterations and several other, including different RAS pathway aberrations. This is again a very nice is a nice illustration that represents the genetic underpinning of the genetic landscape of the PH-like ALL age-wise. So as we can see, the biggest bulk of the PH-like ALL is definitely seen in these two boxes, which basically means adolescents and young adults. And again, re-emphasizing the fact that JAK-STAT pathway alterations is the dominant or the most common PH-like aberrations in which CRLF2 overexpression again forms a big fat component of the PH-like ALL, followed by non-CRLF2 expression and the different ABL class alterations. Well, so when should one suspect and test for PH-like alterations? There is no sine qua non signature clinical marker for this. But yes, it is the prevalence being quite high in the NCI high-risk disease. So yes, NCI high-risk disease, as we know, defined as age more than 10 years and or a presenting white cell count of more than equals to 50,000 per microliter, poor response to induction in the form of induction failure or having a high end of induction MRD, or even a suggestive immunophenotype in the form of a flow cytometry showing you a high expression of TSLP, which is thymic stromal lymphopoietin. And undoubtedly, it has to be the other genotype, the other cytogenetics, because as we know that the PH-like aberrations are mutually exclusive to the recurrent common BALL translocation that we talk about. What should be the strategy for molecular testing? Well, one can, in a resource abundant setting like the COG countries, North American countries, one may opt for an universal strategy where the screening can be done universally for all patients by using an initial low density microarray, and subsequently if the screen is positive, then you go for targeted testing using either NGS or let's say whole transcriptome sequencing. But in a resource constrained setting like us, one has to do a targeted approach in which you do testing only if it is clinically indicated, like high MRD or induction failure, or if it is immunophenotypically suspected, like a high expression of TSLP. In that condition, specifically go for that, and then again a FISH or maybe a multiplex PCR, and if available, an NGS will be the way forward to look for fusions associated with BCR-ABL like or PH-like ALL. So that's what is our approach at Tata Medical Center, Kolkata. So in patients with the other BCP ALL, if our immunophenotype is showing high expression of CRLF2 or the TSLP, our cytogeneticist will immediately perform a CRLF2 break-apart FISH. Otherwise, if it is not showing high expression of CRLF2, we will not immediately do testing for PH-like aberration at the outset. However, if induction response has been poor in this particular selective group of patients, the clinician would intimate this gentleman, excellent gentleman, Dr. Mayur Parihar, who will then perform the break-apart FISH, which includes a panel of CRLF2, PDGFR, ABL, CSF1, and JAK2. And we get the result. So that's been the approach at our center so far. Well, today's era of ALL treatment is all about restratification. So how does one restratify PH-like ALL? Undoubtedly as a high risk because of its known dismal outcome associated with PH-like ALL. The chemotherapy backbone, the literature says, well, one might be using something like a modified BFM approach that is being used by CF, COG, or more intensive SPOL-like regimen. However, the SPOL has now fallen out because of overwhelming toxicity, and the current COG trials are mostly relying upon modified BFM backbone. If we see the upcoming ICICL 2024 in the restratification, I'm sorry, this green level is hiding the fact that PH-like aberrations will be now included in the classification of the high-risk disease. Well, so TKIs. So for ABL class fusions, definitely we have options, imatinib, dasatinib, and even third-generation TKIs, though no TKI is so far officially approved for use of PH-like ALL in children, but they're often used off-label. The data being extrapolated from the PH-positive ALL in children. Now, how does one choose between imatinib versus dasatinib is unclear and is often left on the clinician's discretion. In the PH-like ALL with JAK-STAT activating mutations, yes, we have the option of ruxolitinib, a JAK inhibitor. However, again, it should be used, and the authors of this paper also strongly encourage that it has to be used only in the setting of a clinical trial. And we have a phase 2 dose finding, phase 2 dose right now available. However, one has to use it only under the context of a clinical trial. And if you have an NTRK3 fusion, you can have targeted agent larotrectinib, which is again undergoing a phase 2 clinical trial. So coming to the basic question that how does one treat a pH-like ALL with ABL class alterations? Yes, you use a high-risk 4-drug induction and you add ABL-directed TKI, maybe imatinib, dasatinib, or even higher-generation TKI whenever clinically feasible. And then if the end of consolidation MRD is negative, you are happy, you continue high-risk chemotherapy protocol for 2 years. However, if you have a positive end of consolidation MRD of more than 0.01%, you are dealing with a very high-risk disease, and then the eventual consolidation has to be with allogenic HSCT. However, to achieve an MRD negativity, one can definitely sort for immunotherapies, which could be something like a BiTE approach, or could also be antibody-drug conjugate with inotuzumab or CD19 CAR cells. What about the pH-like ALL with JAK-STAT alterations? So again, as we said that outside of a clinical trial, one should not use ruxolitinib. So classically, one will use 4-drug induction without JAK inhibitor. And if you have achieved remission at the end of induction, you continue consolidation therapy. And if your end of consolidation MRD is negative, you again just continue high-risk chemotherapy for ALL for 2 years. But if at the end of 4-drug induction, you have failed to achieve a remission, then yes, the patient should ideally be included into a clinical trial and the JAK inhibitor should be tested. If you have a positive MRD at the end of consolidation, again, allogenic transplant is a consolidation option and immunotherapy can be used as a bridge to transplant. These are some of the ongoing clinical trials, some of which are exploring upfront use of immunotherapy, and I'm not dwelling on this in great details. So what about the role of immunotherapy in the frontline treatment? Yes, it can offer an opportunity for reduction of the chemotherapy intensity by offering you a chemo-light approach and thus a lesser burden of toxicity. And obviously, it often offers a bridge to transplant by reducing the MRD burden. Ongoing COG trial would probably answer this question in a more precise way in the near future. What about HSCT in CR1? Well, it might be a very debatable question and bone of contention. So far, we don't have any prospectively studied result. This one is a retrospective data from the CENTUR 15 total therapy 15 study, where they have shown that in patients with pH-like BCP ALL who got transplant had a comparable outcome with the non-pH-like ALL, despite the fact that this group of the patients had a high burden of MRD. So that in retrospect proves that probably HSCT in CR1 significantly ameliorates the bad prognostic impact or bad prognostic ramification of pH-like BCP ALL. However, with the mini PPI being on the horizon, the clinician should carefully balance the HSCT-related toxicity and the improving outcome with the new TKIs. One common question is, what about TKI maintenance post-transplant? And probably this concept stems from the fact that in adult, for pH-positive ALL after transplant, often there is data to continue on TKI maintenance. But in the pediatric pH-positive or even in pH-like ALL, we don't have any robust data so far. There is a prospective study which is looking at this matter, because that study is including imatinib maintenance for up to T+365 after allogenic transplant. So whether this approach is really providing any survival benefit has to be seen. Well, management of relapsed pH-like ALL, indeed a very difficult situation. So you go for a 4-drug reinduction strategy, which could be something like an UCAL-R3 protocol as per the center's experience, and you add a second or third generation TKI if it is the ABL class alteration, plus minus JAK inhibitor if it is a JAK-STAT altered disease, indeed under a aegis of a clinical trial. And then once in remission, one uses blinatumomab to achieve a deeper level of remission, and then it has to be consolidated with HSCT in the CR2. However, with this induction, if you fail to achieve a remission, well, situation is quite grim. Then CD19 CAR or inotuzumab. So immunotherapies have to be opted to achieve remission, and then HSCT in CR2. Coming to a brief experience at our center, so as you can see, over a period of almost 8 years, we got hardly 7 patients. So it obviously means that we are missing significant number of cases. So majority of them were young, and the median age was something like 7.5 years. Around 57%, around 60% of them had bulky disease, and around 50% of them had more than 50,000 counts at presentation, with the median WBC count being 46,000. NCI high-risk disease were 57% of them. Only one patient had CNS disease. 57% patient had a step prednisolone good response. So over a median follow-up time period of I think 3.5 years, but we can see that 4 children had experienced an event, 3 having relapsed, and 1 had a treatment-related mortality. So obviously the survival data is yet to mature. So the take-home points are that PH-like ALL is a group of unfavorable biology BCP ALL with a gene expression profile identical to that of BCR-ABL positive ALL. They're genomically quite heterogeneous. Mostly they're present in the AYA population. And when should one clinician check for it? NCI high-risk disease in the presence of poor response to induction, and obviously B other genotype. Treatment is with the high-risk ALL chemotherapy backbone plus minus incorporation of TKI. And there are many unanswered questions, and the ongoing clinical trials are expected to give answers to this in the foreseeable future. With this, I thank you, and these are my questions. And I'm not dwelling on the slide, I'm just leaving it projected. Thank you so much.
Thank you, Preetham. Before going on to the questions, we'll invite our other expert, Dr. Srijesh, to quickly go through the algorithmic approach at lab when we are suspecting PH like ALL. Dr. Srijesh, over to you.
Can you see my slide? Hello, Vinay?
Yes, sir, we can see your slide.
I'll quickly go through the algorithmic approach which we are following in our lab. So before that, thanks Vinay and the team for this opportunity to discuss my experience. Sorry, it's creating something. Can you see?
Yeah, we are able to see.
Yeah, it's moving, right?
Yeah, it's moving. Yeah.
Yeah, fine. Okay. So basically, I would like to start saying that, the laboratory diagnosis of PH like ALL, there is no consensus. If you see all the articles and all the review articles, actually different centers are following very different approaches depending upon the resources available, and their technical expertise and all those different factors. Actually, we cannot have a strategy only for PH like ALL, because any strategy which we are following in the lab, it should be able to capture the major proportion of clinically significant BL categories. And we know that the BLL, the genetic abnormalities, includes aneuploidy, gene rearrangements, large deletions, mutations, the different gene expression profiling. So, any strategy which we are planning to use, it should be able to capture the majority of the categories of BALL. Now, the WHO and the ICC have, there is the newer classification systems, and luckily, the categories are mostly similar between the two groups. So what is very important to understand is we always focus on the rearrangements associated with BCR, ABL1 like or PH like ALL. But actually, it's not just translocations. So because in fact, the original definition is based upon gene expression profiling, and further, they found that there are certain recurrent rearrangements which are very frequent. But if you see that the comprehensive diagnosis of BCR-ABL1 like or PH like ALL requires not only the detection of the translocations, but also several mutations. So this is already described. In addition to this, there are certain mutations. So if we need to identify these recurrent rearrangements. We need to identify the mutations, and there are certain other mutations which increases the likelihood of relapse. So we should also focus on those mutations. So the current strategy in almost all centers which follow the ICT protocol is basically we do a flow cytometry based ploidy. Then we do FISH for these five pro-ETVs. The next one, KMT2A, BCR-ABL1, TCF3PBX, and for the trisomies for 4, 10, 17. But what do we miss if we follow this strategy? We miss a lot of other rearrangements, including the BCR-ABL1 like or PH like rearrangements, MEF2D. There are so many rearrangements. Of course, some of these are high risk and unfavorable, associated unfavorable prognosis. We are also not testing for mutations and other copy number variations. currently what we were following is like we were testing, we were using another set of second panel as Roy described. We were using a second panel of fish probes for ABL1, ABL2, PDGFR-B, FGFR1, CRLF2, P2RH. It's a big panel, you know. So this is done in a selected group of patients, a selected group of NC high risk ALL, sometimes in induction failure or relapse cases. So it's not a uniform thing, but since it was not suggested or recommended in the ICL strategy, but still we were following for last 5 to 6 years. We were doing CRLF2 flow cytometry for some time, but then we realized that actually it is not. In my experience, we have published that it's not actually adding up too much to the overall diagnostic algorithm. So using this particular second panel of fish probes, we could diagnose PH like ALL in about 5% of pediatric ALL and 14% of the adolescent or young adults. Now, again, even if we use the second panel of fish probes, still we miss a lot of other high-risk cytogenetic abnormalities. So the ideal strategy in a resourceful setting would be a combination of whole genome and whole transcriptome. And you know, in AML there is something called chromosig, which has been described. So this is, but this is not applicable to our setting. We cannot go with this particular strategy. So what we can improve and what we are planning in the lab in the next few months is to add in the upfront itself, we are planning to add IKZF17 centromere probe, which will detect majority of IKZF deletions. We plan to add IGH break apart probe, and if it is positive, we should go for CRLF2, MYC, and EPOR as a third line. Why we should add IGH? Even if we go for a targeted RNA sequencing, we must understand that these IGH rearranged BALLs, basically this is kind of a promoter hijacking alteration. So these may not be identified by targeted RNA sequencing. So I feel, and this is what our experience is, that we should add IGH, and if it is positive, go for CRLF2, MYC, and EPOR. We should do a targeted DNA-based NGS for a selected group of genes, so that the mutations which are important to diagnose BCR-ABL1 like ALL and other high-risk mutations like TP53 should be detected. And MLPA can be added if the clinicians feel that not only IKZF deletion, IKZF plus needs to be diagnosed, then we can add MLPA. As a second line, if the above fusion panel is negative, we should go for a targeted RNA sequencing. This is what we are planning to be implemented in the next few months. We have small experience. We have done this this particular approach. We didn't test in pediatric ALL because we are still awaiting the strategy to be implemented through the ICL2 protocol. But when we did this particular strategy, like using a flow cytometric ploidy analysis with a minimal fish panel, together with the targeted RNA sequencing, we could categorize more than 80% of the adolescent and adult ALL as per the latest international consensus classification or the WHO classification system. So what I would like to say is there is no definite consensus, but we can develop our own strategies, and probably this particular strategy I described maybe the most cost-effective approach to capture the majority of high-risk BALLs. Thank you.
Thank you, Dr. Srijesh. Thanks a lot. Preetham, can you project your slide, the question slide, and I would invite the experts, Dr. Rajat, Dr. Srijesh, also Dr. Satya sir, to join in and give their comments.
Right, sir. I'm doing. Yeah, is it visible, sir?
Yes, you can see Preetham. Preetham, I can tell you what happened to my previous hospital in Singapore. We had this strategy of just doing it on a high risk patients or those who had a high MRT NF induction. And the MARSCO 2020 came on, and it was including RNA sequencing for everybody, every child who goes into the trial. If you have only 7 patients in a high volume center over 8 or 9 years, then I'm sure you're missing medications. Now, question is, if you have an early identification, can you change the outcome by adding early imatinib, dasatinib, those sort of things? So, at the moment, I think the strategy you developed is good, cost-effective, but I know transcriptomic analysis is not that costly now. One of the labs, I think, is doing it, if I'm not wrong. So I think at the moment your strategy is fine, but maybe we'll move on to all patients doing this transcriptomic analysis, preferably in a trial if possible. So that will be my thing. Sorry, yeah, somebody wanted to add. Yeah.
Yeah, can I add? Basically,
yeah, please.
Sir, actually, yeah, we also felt that rather than going for bigger and bigger fish panels, keep the fish panel to the minimum, and and then we can add RNA sequencing. We also felt that the RNA sequencing does not add too much to the cost, especially if you are doing in-house and with a very minimal, most important genes. It does not add too much to the cost. The only thing is it has to be a kind of a partner agnostic type of a RNA sequencing, so that KMT2 has more than 100 partners, so you cannot have all the genes in the panel. You need a strategy which is kind of a partner agnostic strategy, so that if one of the genes is in the panel, we should be able to identify the partner by bioinformatic analysis.
Yeah, true. Going quickly through your other questions, whether imatinib or dasatinib. If you take the analogy of the China ALL15 trial, which compared imatinib and dasatinib, they showed dasatinib is better for pH positive ALLs. I mean, it's 320 times more potent than imatinib. So dasatinib would be my choice. I know North American trial in pH positive ALL did not show much difference, but it makes sense. Although the toxicity is significant if you add to a high risk arm. So the MASPORT protocol actually for these patients, they try not to add dasatinib on the high risk. So you're treating with the intermediate risk, but with addition of dasatinib. Length of TKI therapy, I mean, if you're just giving chemotherapy, then stop at the end of chemotherapy. Post-transplant, routinely, we will give for at least a year, if tolerated. That's a problem. Post-transplant, you start as soon as the counts are very good, and no GVHD, and then you start this for at least 1 year, if possible. JAK inhibitor, I have no experience of using JAK inhibitor in this setting, but I saw one thing: the dosage was very high for ruxolitinib, 50 milligram per meter square. That is a very high dose for. I mean, the transplant patients we use for GVHD, much lower dose is used. So, the ruxolitinib, I think it makes sense to use ruxolitinib, but at the dosage, I'm not entirely sure. Last question was HSCT in CR1 advisable in India. Well, I'm not sure. Even transplant has so much toxicity and cost and things. So we should explore all this in a new trial. I don't think no blanket rule can be applied.
Satya sir, quickly your comments.
I agree with most of the answers given. So cost-effective strategy, like in our center, what we do is exactly what Rajat has said. Only high-risk cases or those who are persistently MRD positive, there we check pH-like status. And all relapse cases, we always check pH-like FISH panel. And that helps us decide what targeted therapy to give. And preferred TKI, dasatinib is what I use, and lower doses. And again, toxicity is a problem. And I try to give 1 year post-transplant if patient can tolerate. And JAK inhibitors, we tried in few patients. Even bigger doses doesn't work in those who are refractory to chemo. They tend to not respond even to JAK inhibitors. So, but my experience is less. Maybe some trials or some papers are published. What is the right dose and what is efficacy? How long to give? So let's wait for that. But in my personal experience, I have treated 3-4 kids and they didn't do very well with JAK inhibitors. Then transplant in first remission, again, more data is required. If MRD is negative, patients doing well, you may treat with chemo. I've transplanted one kid, however, in CR1, and that child is doing very well after transplant. Now it's 3 years post, is doing okay. And it was a matched sibling donor. So with matched sibling donor, the risk of mortality is very less. So I would say if a fully matched donor is available and this is pH like ALL is present, you should offer family that transplant is also an option, and then family can decide if they want it or not. So that's what I would say. Thank you so much.
Thank you. Thank you very much. One question from the chat box I would like to take, probably directed to Dr. Srijesh from Venkat sir. Should we move towards NGS-based testing and replace flow and fish strategy for pH, like NGS cost is coming down?
Okay, so basically, there is yes and no. NGS, if you ask me whether it has to be added, yes, of course. If you want to capture all cases of pH like ALL, because the translocations are only as part of pH like ALL. We have activating mutations in the JAK1, JAK2, JAK3, other STAT genes. There are FLT3 genes. So there is a class of abnormalities which will not be picked up if we just go for fish. If you want to capture that particular group of patients, we have to go for NGS. That's definitely we have to do it. And again, fish has its own limitations, of course. We don't know the partner and how many genes can we keep on adding, how many breakup probes can be added. So there are limitations if we just go with fish alone. But it all depends upon what you are going to get with that information. So that's another important question. You can diagnose all these things. You have a rearrangement or you have a mutation. You have diagnosed pH like ALL, but are you going to do something, whether it is going to translate into a actually event-free survival, or because are we going to these children are they going to tolerate high dose therapy? So I don't know how to answer that, but if you want to diagnose all the entire group of pH like ALL, the fish alone is not sufficient. We have to go for NGS, definitely, and if possible, RNA-seq with reducing cost. That's my take on it. There may be a difference of opinion, but that's how we should move.
Okay. Okay. Thank you, sir. Thanks a lot. Very interesting discussions. So I now hand over to Dr. Manas to give the closing remarks. Thank all our experts.
Thank you, Vinay and Shruti, for organizing this. It was indeed a wonderful session. Thank you, Asmita, Dr. Paudel. Thank you, Purvi, Preetam. Thank you, Dr. Srijesh, Dr. Yadav, Rajat, everyone for contributing for this very important session. We had the maximum attendance today with more than 170 attendees. It was a brilliant session, so much to learn. And we'll continue to do whatever best we can in the front of academics for PHO chapter. Thank you, everyone. The next session will be 2 weeks later, where Dr. Michael Schrotter will be speaking on TA-TMA. She's one of the first authors for the Jodel criteria and all the big papers on TA-TMA. So let's hope that, we'll be in big numbers and attend that important session after 2 weeks. Thanks again, everyone.
Okay, thank you.
Everyone. Good night.
And wish you all a happy Holi. Happy Holi, everyone.
Happy Holi, yes. Happy Holi. Bye-bye.
Bye. Well done, Vinay. Can't hear you.
Yeah. Thank you. It was good.
Went very
Nice.
well.
Thanks. Yeah. Okay, ma'am.